Hello, hello, hello. Welcome back in to week 6. You guys have made it to week 6. Congratulations. This is a 16-week EMT-B course, and we are trucking right along. We're going to start tonight with the Cardiovascular Emergencies, Chapter 17. We're going to start there tonight, and I apologize for not being able to go live tonight, but I've had a lot of stuff going on today, and it's going to be a weird week for us anyway. Mr. Larry will not be with us at lab on Tuesday. I'll have some adjuncts in there to help us this week, and we'll still get things done. It's going to be a lot more fun, a lot more hands-on, and we're going to start giving you some scenarios and how to deal with patient assessments and stuff like that. So without further ado, I'm going to go ahead and share my screen, and we're going to get cooking with grease here. Move myself out of the way. So real quick, let's talk about cardiovascular emergencies. Before I get started, I want to go ahead and tell you that this is probably one of the most common calls we run. Is somebody with some type of heart issue going on. Has a lot to do with the standard American diet. Has a lot to do with heart disease being the #1 killer of everybody in America. About 800,000 people die per year of heart disease in America, about 17 million worldwide. And has a lot to do with diet and exercise. And there are some genetic predispositions to certain disease processes, but you can fight that off with the right diet and some exercise and things like that. Though it pains me to admit it a little bit, not really. I myself had a little bit of high cholesterol problem, and I jumped on a vegan diet for about 5-6 months. My cholesterol came down 80, almost 100 points in that 6 months. And there's also doctors and cardiologists out there that can show you data about how a mostly plant-based diet can bring those numbers down. Now, I am not pushing anybody to go plant-based. I'm just saying, that eliminating a lot of animal proteins and fats from your diet can bring it down. That is a fact. But also eliminating a lot of processed things in your diet and eating more of a whole foods thing can make a big impact as well. I have tested it on my own self. I've had labs drawn and checked these things. Honestly, nothing worked better than a vegan diet. I tried it, and I just did not find it sustainable for me and my lifestyle, as active as I am. So I lost a lot of weight really quickly, but I lost a lot of strength too, and I got really weak and tired. And I'm pretty sure it was due to low B12 levels or something I wasn't doing right. Again, not pushing any diet on anybody, but a lot of it is caused by that. So let's get started. We've already talked about the anatomy mostly a bit. With the heart over the last few weeks. So what are we talking about now is the signs and symptoms and management of chest pain and cardiac arrest. So when we say in chest pain, we're saying somebody who's actually having chest pain in this area right here. It usually indicates that the patient might be having a myocardial infarction. A myocardial infarction, or an MI, is the fancy way of saying they're having a heart attack. Their heart is not getting enough blood flow due to a clogged artery, or it could be a spasm of the arteries that has collapsed them down. But either way, if I wrap a tourniquet or a piece of string around my finger, it will turn red, blue, purple, black, and die off. The tissue will die. All organic tissue needs perfusion. The heart is no different. It receives blood flow from the coronary arteries. Now, I know you're all going to disperse and go far and wide with your EMS paramedic EMT careers. This is an EMT-B class. It is entry level, but I can go ahead and get in your mind really quickly that the only way to really know if somebody's having a heart attack is to draw labs on them to read their troponin levels. Only way that's done is in a hospital. Does that mean that the bum that's called you, the homeless guy that's called you, actually having chest pain? I'm not his judge, jury, and I'm not going to be his executioner. So my advice to all of you is if somebody says chest pain, they're the little boy that cried wolf. Your job is to always act like there's a wolf at the door, because it's not my job to figure it out if there is or not. I'll give you a quick war story. Now, I'm not big on war stories, but this one is relevant to the cause. So this is before I moved to the Atlanta area. I lived in Americus, Georgia, worked in Sumter County's 911, and we they didn't have many homeless guys down there. There was this one guy I picked up 2 or 3 times a week, and he always had chest pain. Now, I was warned about him before I even started, and I saw that they were very, very right. He was a frequent flyer that I saw a couple of times a week. Always said he had chest pain, but all he really wanted was a turkey sandwich and to flirt with the nurses at Phoebe Sumter ER. However, I always treated him for actual chest pain. My job is to have a high index of suspicion and to treat these things. So I treated him like he had chest pain. I'd start an IV. I'd give him aspirin. I'd do a 12 lead EKG because I don't have lab value taking capability on the ambulance. And this went on for about a year or two when I was a brand new paramedic. And I always acted like the wolf was at the door. One day I pick him up and he says he's having chest pain. The wolf was actually at the door. I do my normal thing, but my spidey sense is tingling. I could tell something was different. His eyes were set a bit differently. His posture, everything was just setting off alarm bells. My gut instinct saying, hey, something ain't right with my guy here. And I did like I did every other time. I started an IV. I gave aspirin and I did a 12 lead, and there it was. Big, beautiful MI. ST elevation, myocardial infarction. He was having a heart attack. So we shot him on down to Phoebe Putney to the cath lab. He got treated and treated, and he lived another 10 years because of that. But he got like 2 or 3 stents that day. What would have happened if I had not taken him seriously and been treating the wolf like it was at the door? So regardless if you think you're right when it comes to chest pain and heart issues and stuff, you don't have X-ray vision, Clark Kent. And you definitely don't have lab value capabilities. At least here in Georgia, we don't have lab value capabilities on the ambulances. As far as I know, if anybody does, feel free to comment and let me know. That'd be super cool. But for the most part, pre-hospital doesn't do that sort of thing. So the wolf is always at the door. So let's talk about it. We have a couple of things we need to talk about: acute coronary syndrome, angina pectoris, a myocardial infarction, and aortic aneurysm / dissection. Well, they have other things going on, such as thromboembolism, heart failure, and hypertensive emergencies. So, as previously stated, cardiovascular disease has been the leading killer of Americans since 1900. Doesn't look like it's slowing down either. Most Americans are getting fatter. They're eating worse foods. We're not eating a whole foods diet fresh from the farm anymore. By the time food gets to us, a lot of times it's changed hands a lot, and a lot of things have been added to the meat. Not only the meat, but also the vegetables have had all these pesticides, and all this processed food has been through so many things, and it's got more chemicals. When somebody says a beverage has now no sugar, same great taste, to me it sounds like more chemicals, less sugar. So cardiovascular disease is a big killer of Americans, the #1 killer. It accounts for 1 of every 3 deaths. And a lot of it is preventable based on, again, diet, exercise, the way you treat your body. We can help reduce these deaths by encouraging a healthy lifestyle. Now that's a hard pill to swallow, because a lot of us, I know I personally lived off of racetrack and QT and all these curb stores for years because I had such a busy move and groove lifestyle as a paramedic. And I always hated being hypocritical. It's just like me and my partner, we worked at Grady. I'd respond to Georgia Tech, and this kid's been up all night and his heart rate's like 200. He's an SVT, and he's been drinking all these energy drinks and stuff. And my partner would be sitting over there like slipping a monster, like, you should watch your caffeine intake. So same thing applies to you. Practice what you preach. Start bringing your lunch to work and start taking a healthier meal for you to eat. If you want to live a healthier life and have a more active life, that's a way you can do it. Also, people will take you more seriously if you practice what you preach and are more genuine with it. So we can encourage our patients a more healthy lifestyle by taking what we used to call a teachable moment. I'm not sure what it's called now. Hopefully it's still the same thing. If not, somebody let me know what it's called. But a teachable moment would be, well, we're in a more stable environment and the patient's got an open ear, and we just feel like, if you quit eating all this Popeyes and Burger King and stuff, you probably wouldn't be having chest pain. After you get out of the hospital with this heart attack you're possibly having, you might want to think about a salad or something. But again, some people are receptive to that, some people are not. Choose your audience carefully. Not everybody wants to hear what you got to say all the time, you know. And again, your job is to be an objective person in this. So also another thing we can do is we can have early access to medical care, more CPR training of lay people, and increase the use of evolving technology in dispatch and cardiac arrest response. So I'm a really big pusher for um, community education. I hope all of you will become stop bleed instructors, CPR instructors, and get involved in your communities. Not just the one you work in, but the one you live in, trying to make it safer for everybody. When I'm out with my wife and children, I'm not just watching my wife and children, I'm watching yours to make sure they're safe. If I see your kid about to run on the road, I'm going to jump and try and help him. So it is what just a decent human does. But you as a EMS professional, about to be brand new EMT-B, should share what you have with everybody that you meet. Get out there and teach free CPR classes. You can make your job a lot easier if people had some knowledge of what to do in these emergent situations. We can also increase public access to defibrillation devices. You know, if your local gym doesn't have an AED around there, then make sure that you request that they put one there. If these public places that we're at sometimes have access to AEDs, and AEDs are automatic external defibrillation devices, they can convert a quivering ventricle or an arrhythmia called ventricular fibrillation. VFib can be defibbed. And if we have access to that, we could have a lot higher survivability rate of resuscitation. Recognizing the need for advanced life support. So the basics is what save lives. EMT-B magic and medicine that you do, we need you, we love you. Paramedics need EMTs, but there are things that paramedics and hospitals can do that you can't do there on scene just as an EMT-B. So as we teach you how to deal with these situations, and part of your assessment is to call for additional resources. Get you an ALS unit en route to help you. Now, if the ALS unit's 20 minutes away and there's a hospital 5 minutes away, maybe not wait on the ALS unit. Just take the patient there to the hospital doing BLS stuff. That's completely okay. Also taking your patients to special cardiac centers when they're available. So this was more of a challenge in South Georgia, where I worked initially, than it is here in the Atlanta area. You know, I'm like, I don't know, a few miles from a level 1 trauma center at any point in time, with access to a cath lab and all these great stuff. But down there in South Georgia, we didn't have access to cath labs, stroke centers, trauma centers. But knowing how to get my patients to the right spot is what makes a good medic a good medic. If I had a bad trauma, I needed to fly it. I would get additional resources en route. I'd call a helicopter. Hey, come get this guy. And it's not because I want to cost the patient more money, because helicopters are not cheap. But with issues like strokes and heart attacks or myocardial infarctions, that's what we need to start calling them from now on, since you guys have been initiated into EMS now. So for any stroke or MI or any kind of issue where there's a clot blocking blood flow, we need to know that time is money. Time is brain tissue dying off. Time is heart tissue dying off. And the faster we get them to reperfusion, and reperfusion meaning that they have a clot blocking blood flow to their tissue in their heart or brain. And what we need to do is get them to a place that can either remove the clot or bring blood flow around it, or pull that thing out, or whatever they got to do, or perform clot buster drugs. But what we need to do is get them to where they can get that tissue reperfused. You can't do that in the field. So speed is of the essence, but also taking them to the right spot. If I have a patient that is needing cardiac care and I decide to take them to the closer local hospital because I'm about to get off, that is a selfish mistake that I'm making as a paramedic. It is not about me. So what if I get off later? That patient needs to go to a cardiac center, or they're just going to sit at this hometown healthcare hospital and they're going to have to transfer them out. We've delayed care. We've got more heart tissue dying. This is detrimental to patient care. We always have to ask ourselves, if this was my grandmama or my granddaddy or my loved one and they needed to go there, would I skip steps, or would I take them to where they need to go? I think most of us, if not all of us, would say, you know what? While she's back here with me, that's my grandma, and she needs to go to the best chest pain center I can get her to. So I take this lady to where she needs to go, even though it causes me to get off late, or whatever circumstance may be. You have to know that coming through the door. This is what EMS is about. It is a possibility you will get off late. It is a possibility you'll run more than your fair share of calls. Running calls is what we do. But why is this truck getting this call? Because that is the way the cards have been dealt. I promise you, dispatch is not picking on you. It is not a personal thing. Dispatch has algorithms that they have to follow as well. And from once being a supervisor, I can tell you that do not try and dispatch from a truck. You have no clue what you're talking about. You don't hold the cards. You can't see all the pieces to the puzzle. It is best for you just to run the calls you're given, clock out and go home. It sounds so simple when I say it like that. I myself have been frustrated by dispatch a few times, but understanding and after being on the other side of that screen as a supervisor, I know that I didn't have all the cards. And now that I know this information, I'm giving it to you freely. There's nothing personal. Your job is to run calls and go home. They provide excellent patient care. Excellent patient. So what is the heart's job? It's supposed to pump blood, right? Pump oxygen-rich blood to red blood cells into tissues. Now, we talked about this earlier, but just a quick review. The heart has left and right side, upper chambers, lower chambers, the atria on top, ventricles on bottom. Atria receives blood, ventricles pump blood out. All right. There are one-way valves that keep blood flowing in the proper direction. Remember the valves of the heart. We talked about the valves of the heart, the tricuspid, the pulmonic, the mitral, and the aortic. And the way you remember that is the little mnemonic we learned, toilet paper, my anus. Toilet paper, my anus. That is the valves of the heart and in order. That is tricuspid, pulmonic, mitral, and aortic valves. All right, so the heart is controlled by electricity. The heart is controlled by electricity. So electricity makes the meat beat. So the main pacemaker of the heart is the SA node. It's supposed to pace the heart from about 60 to 100 beats a minute. So the heart's a very special organ where it has the ability to perform automaticity. Automaticity, auto meaning self, and maticity meaning electricity. It can generate its own electricity and conduct it and transfer it through the heart so the heart can beat. So there is a bit, the heart does that by itself. The heart generates its own electricity and causes itself to beat. But the nervous system can exhibit some control over the heart via the autonomic nervous system. Auto meaning self, nomic nervous system. So it does a lot of involuntary functions for you. And the autonomic nervous system has two parts, the sympathetic nervous system and the parasympathetic nervous system. This is something that you will hear all throughout EMT and paramedic school. We talk about these guys a whole bunch. Autonomic nervous system has two nervous system parts, the sympathetic and the parasympathetic nervous system. I'm gonna go back and just spend a little time on these guys just a bit. So you have sympathetic, that is your fight or flight. Fight or flight. So this is the sympathetic nervous system. It takes over whenever you're scared or you're about to beat up on somebody. That is your fight or flight. Whenever you need fight or flight, it kicks in and helps you out. It releases a neurotransmitter called norepinephrine and also releases epinephrine, which is another name for adrenaline. And that's what gives you that fight or flight response. It makes you capable of running faster and being a little bit stronger and increasing oxygen to your muscles, and your heart rate goes up, your eyeballs expand, you can see better. It gets you ready for whatever you want to do. Now we got the parasympathetic nervous system. This is your feed and breathe. Oh yeah. So this is more controlling over your vegetative functions like digestion, urination, love making, stuff like that. It has control over that. And these guys work antagonistically against each other. They also have control over your heart rate with their neurotransmitters. They also have control over the size and diameter of your vessels in your body. So fight or flight, releasing that norepinephrine and that epinephrine, it wants to constrict and bring your blood pressure up. Parasympathetic nervous system, that feed or breathe, it will dilate things and will slow heart rate down. So they're always working against each other, but they work together to maintain homeostasis. So the neurotransmitter for the parasympathetic nervous system is called acetylcholine. When we get to medic school, some of you'll learn about acetylcholine, and we can actually have the body, so we can stimulate the vagus nerve in the body and have the patient release their own acetylcholine, which will actually slow their heart rate down. It's called a vagal maneuver. So that is the neurotransmitters and the purpose of those guys. They have some control over the heart rate and vessels and other things in the body. So the myocardium must have a continuous supply of oxygen and nutrients to pump blood. So the heart is a pump, and it needs blood flow and oxygen just as well, just like anything else. So cardiac output is increased by increasing either the rate or the stroke volume. We've learned about that for weeks now. Cardiac output is heart rate times stroke volume. Heart rate times stroke volume. If you want to increase cardiac output, you either bring the rate up or you increase the amount of blood ejected by the left ventricle with each contraction. So the amount of volume pushed out has to increase. In a normal heart, increased blood is delivered to the myocardium by dilating the coronary arteries. That means that they open up. Dilation means to expand. Constriction means to make smaller. And the coronary arteries are the blood vessels that supply blood to the heart muscle themselves. Now, we're not going to get too deep into naming off coronary arteries, but you need to know that there's right coronary and left coronary arteries. That's a big thing there because we got to feed the right side of the heart and the left side of the heart. And if you remember from the anatomy we had a few weeks ago, the coronary arteries bring oxygenated blood and feed the heart itself. And the coronary sinus drain the heart muscle walls of blood themselves and bring it right back to the right atrium so it can be pumped back to the lungs, reoxygenated, and then pumped out to the rest of the body. So there are different arteries that supply different parts of the body. Right and left carotid, right and left subclavian, brachial arteries, radial and ulnar arteries, right and left iliac, and right and left femoral, anterior and posterior tibial and perineal. So right and left carotid, we're talking about the arteries in the neck right here. They're supplying the face, the scalp, the brain with blood flow. Right and left subclavian, we're talking about going down through the shoulder here. The brachial, going through the brachial here. Radial and ulnar arteries are feeding these areas right here. And then we got the right and left iliac. That's the ones down here in the hips. Right and left femoral. Your femoral artery is huge. Your femoral artery goes down through your thigh near your femur. And that's a huge artery going down there. And then it breaks down into the anterior and posterior tibial and perineal. So you have arteries all throughout your body. So arterioles and capillaries. So as the heart pumps out blood, it jumps into the aorta and it's pumped out through the body. It goes through an artery. Let's just take my hand for an instant. The radial artery brings blood here. And it gets to smaller places where there needs to be more microcirculation. It'll pump that oxygenated blood to the arterioles. And then that tissue, my tissues and cells in here will be oxygenated and given that oxygenated blood. And then through net filtration, that blood that was oxygenated now is unoxygenated, will filter through the capillaries and go into my venules. Venules will dump that unoxygenated blood into my veins. And then those veins will dump that unoxygenated blood back into my vena cava. And if you remember, the superior and inferior vena cava is what brings blood back to the right side of the heart so it can be pumped back to the lungs, reoxygenated, and the whole process can go again. So in a nutshell, blood goes round and around, air goes in and out. Any deviation is bad juju, real bad. So blood consists of a lot of different things. Just a quick review, about 55% of blood is plasma. That is the water component of blood. It is a kind of a straw-colored, clear substance going on there. Now, red blood cells make up about 45% of your blood volume, 45%. And red blood cells are important because they do what? They carry oxygen on things called hemoglobin. Red blood cells are produced in the marrow of the long bones, the skeletal bones, through a process called erythropoiesis. Erythropoiesis. And that creates the red blood cells, whose names are actually erythrocytes. Erythrocytes. So red blood cells carry oxygen. White blood cells, their job is to fight infection. Your white blood cells are also known as leukocytes. Their job is to fight infections. Platelets, which help to clot blood, their job is to stick together and form blood clots to save your life if I stab you for failing a test or something. Kidding, mostly. And then plasma, that's the fluid that cells float. Now we talked about blood pressure. It is the force of the circulating blood against arterial walls. Systolic is the maximum pressure generated by the left ventricle forced against arterial walls as it leaves the body. And diastolic is the pressure against the arterial walls and in the ventricle when it's at rest. So systolic will be your top number, diastolic will be your bottom number. Hopefully you guys can remember what the normal blood pressure is. Let's say 120/70 is normal blood pressure. Systolic would be the top number. Diastolic will be your bottom number. It's expressed as a fraction. And pulse pressure will be the difference in systolic and diastolic. That'd be your pulse pressure. Go ahead and erase this and we'll keep on moving and grooving. All right, so a pulse is felt when blood passes through an artery during systole. So basically, left ventricle contracts. And as that bad boy contracts, it sends blood going throughout the body. A pulse is felt when a pressure wave is pushed out throughout the body, and it's felt when you compress an artery against a bone. You can feel peripheral pulses in the extremities and central pulses near the body's trunk. Mainly, we stick to radial pulses for conscious patients. Unconscious, we'll run up to the carotid. For children and babies, we'll do a brachial pulse. So radial here in the wrist, brachial here around the bicep area and elbowish area. And then, of course, we have the carotid over here in the neck meat on the side, either side. Everybody take a second, just feel, make sure you got a pulse. If you don't, you're a zombie. So quick look at it. Let's take a look. So you can check carotid pulse. I don't know why this guy's doing 3 fingers. Maybe he knows something I don't. So you can feel that in the neck. The brachial here, it's right here through the bicep elbow area. Posterior tibial. That's going to be right there behind on the back side of the tibial. So tib, top bone here. Fibia is back here. It's the bottom behind the leg bone. And then we got a pulse behind that. Then the pulse on the top of the foot is called the dorsalis pedis. Now, why would you want it to be able to and know to check pulses in these limbs? Well, let's say one of you guys is rolling down the street and you're on your scooter and you fall off and you twist your ankle, and we get there and it's broke. It's a broken ankle. Now, I need to make sure that that foot below the brake is still getting blood flow, because if it's not, then he has stopped blood flow there. He has poor perfusion. And if he doesn't have blood flow, then that tissue down there will become ischemic. It will turn red, blue, purple, black, and die. The tissue will die, and this dude could lose his foot. So it's very important to be able to check pulses in extremities. Same thing can apply to your wrist or your hand or any other thing like that. Dude's got a broken arm, or if I'm just being thorough, checking my patient's extremities. When I check a patient for injuries, I'm checking for dorsalis pedis and posterior tibial. I'm making sure they got pulses in these feet, so I know that they got perfusion in those limbs. Also, when we get to trauma, we'll talk about this again, but just as a heads up, whenever we put somebody on let's say you did break that leg and we're going to splint it. Before I put the splint on, I'm going to make sure that you have pulses, motor sensation, which means you've got pulses, so you got blood flow. You can kind of move the leg or foot a little bit, and you can feel me touching you. PMS, we're checking for PMS, pulses, motors, and sensation. Now, after I've applied the splint, I want to make sure that they still have pulses, motors, and sensation. If they don't, and they had it before, it's most likely I've got the splint on too tight. Now let's move to the femoral. Now the femoral artery is kind of personal, as you can see. It's felt on the inner part of this groin there. Now that femoral artery is pretty big. It's about the size of your thumb. It's big and wide. You should feel it. If they got a pulse down there, you will feel it. Just be careful. Don't get yourself a lawsuit. Radial, we've worked on this in class and lab a few times now. The radial pulse is felt on the top of the wrist there, and the dorsalis pedis against top. So again, cardiac output is the volume of blood that passes through the heart in 1 minute. Perfusion is the constant flow of oxygenated blood to tissues. If perfusion fails, cellular and eventually patient death will occur. Patient death will occur. All right, so let's talk about chest pain. Again, one of those common calls we run, and it doesn't mean it's always going to be some old geezer that's been eating McDonald's his whole life. I have ran I think a 14-year-old that had actual chest pain that was actually having a myocardial infarction. He had sickle cell, and it caused him to, his red blood cells are shaped funny, and it caused him to have a blockage in his heart, and it caused him to have cardiac ischemia. Just because it's not as likely at a younger age doesn't mean it can't happen. I worked a 19-year-old cardiac arrest, and after she didn't make it, she died, and she had died of a heart attack. Now, she was also 400 pounds, and they found a lot of cocaine in her system, but that's still not an excuse. It can happen at any age. So always keep a high index of suspicion. That means if somebody says chest pain, treat it like chest pain, because you don't have x-ray vision there, Clark Kent. And because it's, again, you're not there to judge them about what they called for. You treat what you see, you treat what they tell you, you form a good assessment, take a great history, treat the symptoms you see. And if you got any questions or comments or whatever, just make sure you call your med control. And if you get stuck, call somebody. We're not in this thing alone. We're doing what's best for our patient, which means you can make a phone call. So chest pain usually stems from ischemia. And ischemia means low oxygen, low blood flow. So ischemic heart disease involves a decreased blood flow to one or more portions of the heart. And again, if I take a string wrapped around my finger, it'll turn red, blue, purple, black, and die. The heart's doing the same thing right now. If blood flow is not restored, if reperfusion does not occur, this tissue will die. The tissue will die. So let's take a look. Atherosclerosis. I'm going to go ahead and make a note here. So atherosclerosis is the buildup of calcium and cholesterol in the arteries. This is your KFC, chick filet. I can both get you. This is where your fried foods and all these animal fats and lipids are building up. Again, I'm not pushing the vegan diet, guys. It's just how it works. This is what causes this to happen. Matter of fact, Dr. Caldwell Esselstyn, the cardiologist, I think he works at the Cleveland Clinic. He had a saying, most cardiologists are vegan, and the ones that aren't haven't read the data yet. And he's very compelling. Again, I ain't trying to get you to change your diet. I'm just letting you know, hey, this is a buildup here. So cholesterol is what's causing this right here. It's a big cause of it. Now, the difference between atherosclerosis and arteriosclerosis is what? Atherosclerosis is a buildup of plaque and cholesterol. Arteriosclerosis is a hardening of the arteries. I want you to remember arteries, art hardens, paint hardens. So arteriosclerosis is a hardening of the arteries. Atherosclerosis is a plaque buildup. I have seen those questions on registry. I have given those questions to lots of students, and both of them sound and look so similar that I myself, even though I wrote the question, have to stop and really look at it for a minute to be sure. So normal blood flow is going on right here, and this pink, it's that yellow stuff. That's your plaque buildup. See, it narrows the artery, which will decrease blood flow to tissue. Now let's talk about it. A thromboembolism is a blood clot floating through blood vessels. If a clot lodges in a coronary artery, there could be an acute myocardial infarction. So let's say a thromboembolism usually those come from DVTs or deep vein thrombosis. It comes from possibly the legs. And let's say Granny has been on this flight for, this happens a lot of airport division we have. Granny's been on the flight for 12 hours, been sitting, she ain't moved, she stands up, clot breaks off, travels to her heart. Now she's having chest pain. It's not a good day. So if a clot lodges in the coronary artery, remember coronary arteries supply blood flow to the heart muscle itself. An acute myocardial infarction or an AMI results. So a myocardial infarction is, again, what is that? That's a heart attack. Now that you are in medicine, you're not lay people anymore. You do not just call it a heart attack unless you're trying to get a lay person to understand what you're talking about. We in EMS and in medicine, we call it a myocardial infarction. Now, acute myocardial infarction, an acute. So acute means it is very sudden. It just happened. Acute means just now it occurred. Chronic means that it's a long-term reoccurring event. If you have chronic hypertension, it means that you've got hypertension all the time. But if your blood pressure is normally normal and you suddenly have high blood pressure, you have acute hypertension. See the difference? So remember these terms, AMI, acute myocardial infarction, or MI, myocardial infarction. They're forms of shorthand that are used a lot in medicine and on tests and all that kind of stuff. So make sure that you're paying attention to that stuff. So coronary artery disease, leading cause of death in the US. Controllable AMI risk factors. Let's talk about it. Cigarette smoking. Yeah, you can control that. High blood pressure. You can control that. Some people are just genetically predisposed to have high blood pressure. Just about 50% of the population has high blood pressure. I had high blood pressure diagnosed when I was 17. And I was in really good shape. I had abs. I ran every day. I played baseball. I mean, I was in great shape. But I had high blood pressure. My granddaddy had it. My dad had it. And they were all in good shape too. I mean, I'm chunky now, but I'm on my medicine. My blood pressure runs 120/70. It's perfect. So can I control that risk factor for myself? Yes, I have normal blood pressure because I take blood pressure medicine. High cholesterol, getting your yearly physical and labs drawn, making sure you've got lower normal cholesterol levels can reduce your risk of having an acute myocardial infarction. Diabetes, like Wilford Brimley. So diabetes can be controlled with diet and exercise and by taking your medications. And of course, lack of exercise and obesity can play a role. Uncontrollable risk factors would be older age. As we get older, our arteries and veins, they get stiffer and you're more at risk for certain things like that. So family history, if your great granddaddy had it and your daddy had it and then this other person. So some things you can't control. Atherosclerotic coronary artery disease. Your race has things to do with ethnicity and sometimes being male. There are certain disease processes that are more prone to females, or some more prone to males, or some more prone to dark-skinned individuals, and there's some more prone to light-skinned individuals. It has a lot to do with all these things. You can't control your race. You can't control your ethnicity. You can't control a lot of things like that. So acute coronary syndrome. We typically call ACS, or acute coronary syndrome. It's caused by myocardial ischemia. It does not necessarily mean they're having a myocardial infarction. It does not mean they're having an MI. They could be having angina. Angina is when the heart is not getting enough blood flow and the chest will start to hurt. So angina pectoris is a lack of blood flow and it causes chest pain. That is, angina pectoris is chest pain that is not an MI. Acute myocardial infarction, that is an MI. That is a heart attack. That is what's going on, a sudden myocardial infarction. We got 3 levels to this thing. We've got ischemia, injury, and infarct. Let me go ahead and just do a little in out. So ischemia is number 1. That's just low blood flow, low oxygen content. Injury Injury is when we got that tissue that's not getting enough blood flow. It's starting to have some damage occur. And then you got infarct. Infarct means dead meat. So we got three of these, three I's: ischemia, injury, infarct. Ischemia is just lack of blood flow. Injury is when there's actual damage starting to be done. And infarct is the tissue is dead. And remember, if the patient survives this, that tissue's not coming back. Dead meat don't beat. This is how people develop conduction issues with their heart. This is how people develop congestive heart failure. Because if they've had a big, massive myocardial infarction or a heart attack, and that heart muscle on the left ventricle was damaged, it doesn't do its job anymore. It doesn't expand and contract, and doesn't squish together and push blood out, doesn't conduct electricity, it doesn't do anything it was supposed to do anymore. Dead meat don't beat. So angina pectoris is when the heart's need for oxygen exceeds the supply. We got a supply and demand issue going on here. The heart needs more oxygen than you can supply. They have a crushing, squeezing pain. Does not usually lead to death, permanent heart damage, but it should be taken as a warning sign. I would say that angina is a precursor or a warning sign of a MI that's going to occur eventually, especially if a patient's been diagnosed with just angina, and they will have an eventual heart attack. I mean, most likely they will. So unstable versus stable angina. Unstable versus stable angina. Unstable angina occurs in the absence of a significant increase in oxygen demand. And stable angina occurs in response to exercise or activity that increases demand on the heart muscle. So another way of looking at this is, let's say grandpa's out there cutting grass and he starts to get chest pain. He sits down for a few minutes, maybe pops a nitro, and his chest pain goes away and he feels good. Stable. Unstable is he sits down, he rests, he pops nitro that he's been prescribed, and it still occurs. He's continuously having angina. Treat angina patients like AMI patients. I love that. Because again, I have no way of really knowing, are they having a heart attack or an acute myocardial infarction? I don't know for sure. I don't know for sure because I don't have x-ray vision. I don't have the ability to draw lab values on the truck. Now I can stick them on an IV and they can bleed out, but I have no machines to read what their troponin levels is. When the heart is under stress and there is dead and dying and injured ischemic tissue, it will release chemicals into the bloodstream that we can pick up. So if the heart is under stress, we can read blood levels. But in the pre-hospital setting, we cannot. Again, unless that's something going on in another state, maybe a critical care unit or something of that nature. But here in Georgia, it ain't happening. At least the services I know of. So let me go back to this. Just treat everybody that says chest pain like they're having an acute myocardial infarction. You don't know. What if it's the bum you've picked up 10 times this week? I don't care. I don't care. The boy that cried wolf. Well, there will eventually be a wolf there. Are you going to let it eat him and you, or are you going to be the good shepherd and be ready? I promise you, if you stay ready, you ain't got to get ready. Don't let the wolf catch you slipping. Free advice. So acute myocardial infarction pain signals actual death of cells in the heart muscle. Once they're dead, the cells cannot be revived. Once they're dead, the cells cannot be revived. Dead is dead. Dead meat don't beat. So clot busting thrombolytic drugs or angioplasty within the first few hours prevents this damage. The faster you get them to reperfusion, which is a cath lab where they can do a cath, what they'll do is they'll stick a kind of a wire either in the radial or the femoral artery. They'll migrate that some of them up to the coronary arteries. They got options then. They'll inject dye and see just how much of a blockage they're dealing with. Just how much of a blockage they're dealing with. Now, they could fix it with, let's say, these clot busting drugs. Now, what do you think when you hear clot busting? Exactly what it sounds like. There's clot there. We're going to give them drugs. It's going to bust them out. Doesn't always work. Angioplasty or a cabbage or a coronary artery bypass. So we got the balloon. So they'll migrate that little thing up there. So let's say this is the artery right here. And this is the clot that's formed. Let's put a little heart right here. Y'all excuse my drawing because I'm not great at it. So we got blockage right here, and it's stopping the blood flow in the heart. He's sad. He's crying. He's a tear, bro. All right, because he don't have blood flow. He doesn't feel good. The heart doesn't feel good. It ain't got blood flow. So we got options. What they can do is they can put stents in. So they'll just put a little straw in here, and they'll widen the straw and push this fat down. And that'll actually do what? It squishes this stuff down. And then the straw can actually help blood flow go through. Make sense? Next thing they can do, if there's a clot here, is they can stab the wire through it, inflate a balloon, and then pull the thing out. All right. Now let's go back and let's talk about this. So that's another option they can do. Now, what if this clot is completely occlusive? Completely occlusive. So we talked about busting with drugs. We talked about putting a stent in there, which is again, we put the straw in there and expand this straw and more blood flow can go through this area. We talk about stabbing it through with a wire and the balloon inflating and pulling the pot thing out. Those are all options when there is room to do so. Now, what about when that thing is fully occluded? The heart will be under much duress, and the patient will need what's called a cabbage. A cabbage, C-A-B-G, coronary artery bypass graft. Coronary artery bypass graft. So if you live near or around Atlanta, you know what a bypass ramp is, right? It's to get around something. So what they'll do is they'll take a vein from dude's leg and they'll just bypass this big old clot. They'll take it and they'll graft it in. So coronary artery bypass graft. They'll take a little vein from the leg and they'll graft it into this coronary artery and blood will flow around and the heart will become happy. So I know I'm a terrible drawer, but I'm just trying to give you some visual aids here. So a coronary artery bypass graft or a cabbage is kind of a last result. That's when they split the chest open, they open this bad boy up. That is open heart surgery. The rest of the stuff I was talking about, the angioplasty, the stents, everything else, that can be done in a cath lab. Most cath labs can perform that, but not all cath labs can perform the cabbage. They need open heart surgery and a cardiologist, cardiothoracic surgeon, or something for that. So these are important things to know. What the hospitals you're taking these guys to is capable of. But you wouldn't know how much occlusion they have anyway, but you just need to take them to the closest cath lab available. So again, if you're the EMT and you've got a paramedic there, and I urge you to urge them to do 12 leads on everybody. It takes only a minute or so, and you can find out a lot of information. 12 lead your patients and make sure you're taking them to the closest cath lab, and don't spend a whole bunch of time on scene. I hate to say it, but this is one of those situations where we don't need you to be rescue Randy on scene. We need you to grab and go. I'm talking about a 10-minute or less on scene time, if at all possible. Now, if you've got 50 stairs to go up and there's all this extrication issues going on, hey, I get it. I'm just telling you to be as expedient as possible. Just be as expedient as possible. So what are the signs and symptoms of an acute myocardial infarction? So weakness, nausea, and sweating. Weakness, nausea, and sweating. You will feel weak and tired if your heart's not beating right. If it's under duress, you'll feel weak. You'll be nauseous. You'll feel like you want to throw up, and you'll be sometimes diaphoretic. Sweating is diaphoresis. Sweating is diaphoresis. Diaphoresis, or being diaphoretic, is the medical term for saying sweat. Make sure we know these terms for our test. Chest pain or discomfort, substernal chest pain, usually located in this area right here. So what we're looking at here is substernal chest pain that is right here. That's where it will usually, not in all cases, but usually occur. Discomfort or pressure, they don't always say it's a sharp stabbing pain. A lot of times they'll describe it as a more of a discomfort pressure. There's an elephant on my chest kind of thing. Irregular heartbeat, syncope. Syncope is what? Syncope is a momentary lack of blood flow to the patient's brain, and it will cause sometimes fainting. Syncope is fainting. Shortness of breath, which is dyspnea. Nausea, vomiting, pink frothy sputum. Now, pink frothy sputum is usually due to a weak and baggy left ventricle. If the left ventricle is not beaten correctly and not pumping all the blood out of the heart, that blood will back up back into the lungs. Remember the path of blood through the heart? It will back up through the lungs, and that patient will have fluid in their lungs. It's called pulmonary edema. They'll have fluid or blood in their lungs called pulmonary edema, and it'll be hard for them to breathe. Pink frothy sputum, I want you to associate that with CHF, congestive heart failure. It's one of those big tall tale signs of CHF. Pink frothy sputum, that means that there is red blood cells inside their sputum there. Or just suddenly dropping dead like that. Sudden cardiac death can occur. How and why? Well, many reasons, like an arrhythmia can be triggered because of ischemia to the conduction system, but another reason would be a clot at the exact perfect spot. So a fork in the road exists at the left main coronary artery. All right, there's a fork in the road. And at that fork, the left main divides to the left anterior descending and the left circumflex. If a clot forms right here in between both of them, it'll cut off blood supply to both of these coronary arteries. That's usually sudden death occurrence. Usually it's sudden death. If there's a clot that forms at the left main coronary artery before it splits at the fork in the road, it is called the widowmaker. Why do you think it's called the widowmaker? Because it will kill you and make your wife a widow. AMI pain differs from angina pain. A myocardial infarction is not always due to exertion. Usually lasts 30 minutes to an hour, and it's not always relieved by nitroglycerin. Remember we talked about nitroglycerin last week when we talked about pharmacology in the lab. Nitroglycerin is a great drug because it will dilate and allow for more blood flow to go into the heart muscle. But an MI is not always going to be responsive to that because the clot is so big in there. Some AMI patients may not even realize they're having a heart attack. Let's talk about it. I can think of 3 patients with some autonomic issues that would cause them not to present normally. We went over the signs and symptoms of a possible acute myocardial infarction just a few minutes ago. Things like nausea, vomiting, chest pain, shortness of breath, blah, blah, blah. There are 3 types of patients that may not present normally. They could be sitting there talking to you and you would never know they're having a heart attack because they don't even know. So let's talk about elderly, women, and diabetics. Any of those 3 cannot present normally. Any of those 3 could be having a heart attack and you guys would never know it. This is why, like, I go to the old lady, oh, I just feel weak today, baby. I don't know what's going on. It's just crazy. I was out cutting the grass and god dang, I just feel weird now. She doesn't say she's having chest pain, difficulty breathing. She's a spitfire. She's still moving around, talking and, flirting with my partner, all kinds of things. But then I put her on a 12 lead because I 12 lead everybody. Oh, there is ST elevation. Ooh, there. She is having an acute myocardial infarction, but not presenting normally. She presents atypically. A means without type. Atypically. She presents atypically. So this is the type of patient we want to be very careful with and make sure that we're looking for. Also, again, if you 12 lead everybody, you won't miss these type of things. Not everybody shares in that philosophy, and I don't really care. I'm gonna do what I gotta do. I'm gonna do me. And because you guys represent me, I want you to encourage your paramedics to do the same thing. Or if you're just, if you're putting on the EKG, go ahead and throw a 12 lead on. Like, oh, this looks funny. What do you think, Mr. Paramedic? Oh, dang, she's having an MI. I guess we should take her to the cath lab. Good idea. Great idea. So AMI and cardiac compromise, you'll have fear, nausea, poor circulation, fast, irregular, or bradycardic pulse, decreased normal or elevated blood pressure, normal or rapid respirations. Patients will have that impending feeling of doom. I'll tell you this, if a patient ever turns to you and suddenly says, I'm about to die, I would believe them. They know something's going on. They can't always put words to it, but there's an intangible something going on there. If a patient feels that impending feeling of doom, they are probably about to die, or at least they're circling the drain. You could intervene though, get that reperfusion going on at the cath lab, and they could live. There are 3 serious consequences of an AMI. 3 serious consequences. You could die immediately. That'd be bad. The patient could go into cardiogenic shock. And cardiogenic shock is the form of shock we talked about last week, where the heart muscle is too weak to meet the metabolic demands of the body. It's not pumping out enough blood. The blood pressure is too low to reach the cells and tissues of the rest of the organs of the body. And they're all ischemic and they're all poorly perfused. So the patient's in a form of shock. Congestive heart failure is another consequence. Because there's dead meat on the left ventricle or in the heart now, the patient could develop congestive, it's congestion, it's a lot of fluid extra buildup, and heart failure. Let's put it all together. Congestive heart failure. They could have excess fluid that's not pumped out of their left ventricle back up into the lungs, causing pulmonary edema. They can also have a weak heart, difficulty breathing, nausea, vomiting, PVCs from an irritated ventricle. Lots of things can occur there. So a dysarrhythmia would be what? So a dysarrhythmia or an arrhythmia, whatever you want it to be, a dys meaning difficulty, painful. Dysrhythmia is a heart rhythm that is abnormal. Most of us are operating in a normal sinus rhythm right now, where all the little bumps on the EKG are doing what they're supposed to do. When a dysarrhythmia occurs, there is electrical issues going on in the heart, such as premature ventricular contractions or PVCs. A PVC usually indicates irritated ventricular meat. A PVC is not a real heartbeat, but it's an actual ectopic foci, meaning that some of the cells, the pacemaker cells that have that automaticity going on, they have enhanced automaticity where they're having extra electrical activity go on, and they will spontaneously depolarize the left ventricle. What does all that mean? Okay, so there is a cells over there in the ventricles that are kind of ticked off because they're not getting enough blood flow and oxygen. So they start creating more electricity and they get pissed off, and then they cause the ventricle to prematurely contract earlier than it was supposed to. It makes it come earlier and beat earlier. Then we have tachycardia, when the heart rate jumps over 100 beats per minute. Bradycardia, where the heartbeat goes down below 60 beats per minute. Ventricular tachycardia is when the ventricles are now running the show. The pacemaker cells down there are beating fast, and it'll have a big, wide complex that is dangerous to the patient. It is not sustainable for very long. VTAC can have a pulse, but it will eventually become VTAC without a pulse. It's a very dangerous rhythm. And then we have ventricular fibrillation. There is not going to be a pulse with VFib. The patient's heart is no longer beating or contracting. What is it doing? It's quivering. It's not pumping. It's quivering, fibrillating. So how can we fix a lot of that? Well, with VFib, you can defib. You can defibrillate. So stop the fibrillation process. Defibrillation will restore normal cardiac rhythms. The only shockable rhythms we have, though, are pulseless VTAC, pulseless ventricular tachycardia, and ventricular fibrillation. So pulseless VTAC and VFib are the only shockable rhythms. Defibrillation can save lives and initiate CPR until the defibrillator is available. Now, you as the EMT will not be able to read these heart rhythms and be able to defibrillate manually. That's a paramedic skill. However, if you have an AED and you apply it to the patient's, place pads on patient's bare chest, stand by, analyzing rhythm. As it analyzes the rhythm, that AED can automatically tell you or can recognize that the patient's either in pulseless VTAC or ventricular fibrillation, and it will say, hey, shock advised. So if it advises a shock, the patient's in one of those rhythms and they will need to be shocked. If you defibrillate them, you can then restore that rhythm. Now, after that defibrillation hits, boom, they hit that electrical charge, their body will jump all crazy like. We're going to want to start CPR again. Why? Because we need to prime the pump, put more blood flow going on in there. After 2 minutes, we can check. Oh, you got a pulse back. Look at me. And that is great if that's all done correctly. Now, asystole, A means without. A means without. Systole means there's no rhythm. That is the absence of all the heart's electrical activity. Reflects a long period of ischemia. Nearly all the patients that have asystole will die. This is usually the cardiac standstill. This is the rhythm that you see on all those ER shows when somebody's dead. They don't normally go into like a VFib or a VTAC. This is the systole. See that long line of nothingness? That's what their EKG will read. There's no anything else. It's just patient is dead. One of the funniest things that we see happen on a lot of these ER shows is that a lot of these nurses and doctors are trying to shock asystole. And that's not how EMS and that's not how AHA guidelines are formatted. You do not shock asystole. It is not warranted as far as the pathophysiology of that heart. What asystole needs is epinephrine and CPR. And for you to find the causation of the cardiac arrest, and hopefully take care of that, and you might get the patient back, maybe. Now, cardiogenic shock, often caused by a heart attack. The heart lacks the power or force enough to put enough blood through the circulatory system. And that's inadequate pump, this is a pump problem. Inadequate oxygen to body tissues causes the organs to malfunction. The organs will start to malfunction and die off slowly one by one. If you recognize shock in its early stages, you can act quickly and treat this patient and help them tremendously. Congestive heart failure occurs only a few days following after a heart attack. It can occur. Increased heart rate and enlargement of the left ventricle no longer make up for decreased heart function. So the heart rate will go up and the ventricle will no longer make up for that decreased heart function. Lungs become congested with fluids, may have dependent edema. Now, dependent edema is what? It's when the patient has fluid that is in places outside of where it's supposed to be. It's like if the patient's ankles are swollen up this big and you push on it and it leaves a mark, that is called pitting edema. But dependent edema is when they have fluid in their legs, their sacral edema, and in places it is not supposed to be. Fluid retention like that is usually a sign of a heart issue. Now, what about hypertensive emergencies? Hypertensive emergencies. That is when the systolic pressure is greater than 180. That is when the top number of the blood pressure is over 180. Now, remember, we have chronic hypertension, which is it happens all the time, or acute hypertensive emergency. Hypertensive emergencies do occur. And at least I don't know about other states, but here in Georgia, we do not treat blood pressure in the field. We do not give anything to bring it down. This is an ER issue, but we can recognize it, call a report, and have them ready to treat it as soon as we get there. So systolic pressure greater than 180 is typically and technically a hypertensive emergency. The patient could have sudden severe headache, strong bounding pulse, ringing in the ears, also known as tinnitus. Ringing in the ears, also known as tinnitus. These are signs and symptoms of hypertension, hypertensive issues. The blood pressure is too high. So what else could happen? Nausea, vomiting, dizziness, warm skin. Their nose could start to bleed. They could have altered mental status and have sudden flash pulmonary edema where there's blood flow, there's blood and fluid in their lungs. If it's untreated, it can lead to a stroke or a dissecting aortic aneurysm. So a stroke is what? It's when there is a blood clot in the brain or there's an aneurysm in the brain that can occur. We have ischemic strokes and hemorrhagic strokes, which we'll cover here in a little bit. But either way, hypertensive crisis can cause a stroke. Transport quickly, consider ALS assistance, but that main thing is get that patient out of there. Now, what about an aneurysm? Now, an aneurysm is a weakened portion of a vessel's wall. And remember, we talked about it last week in lab, is let's imagine you leave the water hose on in a high pressure system. That water hose is normal, then it starts to form that bulge that gets bigger and bigger. That bulge would eventually pop and all the fluid will flow out of the water hose. Same thing can happen in your body. In your body, you have an aorta that goes right through the trunk of your body. And that bad boy is big, about the size of maybe your two thumbs put together or bigger. Big old pipe right there. Now, what happens is that the tunica intima and the tunica media, they will start to weaken and tear, and that fluid, that blood, will start to seep out into the tunica adventitia, which is the outer lumen of the vessel wall. And what will happen is that it forms that titty on it, that bulge, and it will eventually pop. It could leak first, but when it pops, you could probably be on an operating table, and I would still say there's a high chance of you dying. So a AAA is an abdominal aortic aneurysm. It is a weakness in the wall of the aorta. It is susceptible to rupture. Dissecting aneurysm occurs when inner layers of the aorta become separated. Primary cause is uncontrolled hypertension. Uncontrolled hypertension, which is preventable because you can take medicine and prevent this, but a AAA is very deadly. It also presents funnily. The patient will sometimes present with chest pain that radiates to their back. And as it radiates to the back, as they describe it to you, as you go through your OPQRST, when you get to quality, you say, so tell me what it feels like. What's going on there? I mean, tell me how the pain feels. Is it sharp? Is it stabbing? And they'll describe the pain. I feel pain in my chest, and it radiates to my back. It feels like it's tearing. That tearing sensation is the aorta tearing. And that is also a buzzword for National Registry. It is very, very common to see that. But they're trying to get you to figure out that it's a AAA. They could have very sudden chest pain, and it comes on full force. They could have different blood pressures in either arm. It actually may be difficult to tell the difference between a dissecting aneurysm and an AMI. Either way, assume the worst. Treat your patients quickly and safely. Get out of there, take them to a cath lab and a place that they can get the care they need. So let's do a differentiation here. Acute myocardial infarction versus a dissecting aneurysm. Onset of pain, gradual. Dissecting aneurysm, abrupt. The quality of the pain, what they describe. An AMI, they'll say tightness or pressure, or there's an elephant on my chest. Sharp or tearing pain that will again be felt in the back. Severity increases with time for an AMI. Dissecting aneurysm would be maximum 10 out of 10 right from the get-go. Timing of the pain may wax and wane, may get better and worse. Not a AAA, not an aneurysm. It will be bad from the start and it won't get any better. Where does it radiate? So an acute myocardial infarction will usually be substernal, right? So sub right here, sternum in this area. And it could radiate to the left jaw, the left arm, the right arm. It could radiate there. Rarely will a myocardial infarction radiate to the back, but a abdominal aortic aneurysm, possibly, if it's involved, that pain will be in the back as well. It'll be between the shoulder blades, and it will be, again, that'll be that tearing sensation that we're talking about. Clinical other signs are peripheral pulses will be equal, and in the dissecting aneurysm, blood pressure discrepancy between the arms can occur. Why is that? Because the aorta is a giant vessel going through the trunk here, and as the blood is pumped out of the left ventricle, it goes into the aorta, and the aorta curves around and goes down here. Then it splits and feeds the arms. It splits that down there and at the bottom, and feet turns into femoral arteries. So if there's a leak there, there will be a change in blood pressure going on because that femoral is feeding all the other arteries in the body. So let's take a second here and think about this. So at this point in the PowerPoint, what would happen is that they would teach you to go back through your primary assessment and then go back to your secondary assessment and, of course, your history taking, which means you can do that here. We're going to practice this in lab this week, actually. We're going to practice this in lab. We'll give you some cardiac scenarios, let you run through them, and let you kind of figure out kind of a flow of questioning and how to deal with quite some patients. If I can, I'll get them to let us borrow a ambulance, and you can run calls as if you were a real EMT. So, of course, we want to start with scene safety. Scene safety being what? Regulations 1:9. If the scene is unsafe, thou shalt dippeth out. Next, we would talk about continuing that scene survey is like, if it's safe, I'm gonna wear my gloves, my mask, whatever I need to be safe in this environment. And then I would look at what? The mechanism of injury or the nature of illness. The nature of illness is chest pain. Okay. I know I'm going to a chest pain patient. How many patients do I have? And if you haven't got a copy of the primary assessment sheet, I'm gonna try and email it to all of you today. So after that, how many patients do I have? Do I need additional resources? And what I consider C-spine. Then you would form a general impression of your patient as you approach them. As you approach, you see a, let's say, 45-year-old male patient clutching his chest like this. Clutching his chest like this is called Levine's sign. Clutching their chest like this is called Levine's sign. It means that they're having chest pain, right? Possibly indicating an acute myocardial infarction or AAA or angina. It's hard to differentiate between all of them. If somebody says chest pain, assume it's the worst thing in the world that's happening. It's the biggest acute myocardial infarction ever. Treat them quickly, 12 lead, IV. Well, you can't do an IV, you're an EMT-B, but getting them out of the scene and towards a cath lab is the best thing you can do. Helping your medic to start an IV by setting it up for him and putting on a 12 lead EKG for him so he can read it and interpret it. Another thing, after that, you can transmit the 12 lead via Bluetooth to the cath lab you're going to. The cardiologist can read it before you get there. There's a lot of steps to this, but the main thing is if there's a chest pain patient, don't spend time lollygagging on scene. 10 minutes or less and get out of there. 10 minutes or less and get out of there. So after we formed our general impression, we want to check their level of consciousness, their LOC. Are they alert, verbal, painful, or unresponsive? These are important to know. And then we want to check the patient's airway. Is it open and patent? Breathing, rate, rhythm, quality. Circulation, rate, rhythm, quality, skin color, temperature, moisture. And then we make a transport decision. I'm going to go ahead and tell you, I'm not a big believer in staying around and hanging out. So always load and go. And for your national registry purposes, always load and go. All right, so that's going to be cardiac for us this week. Any questions, comments, concerns, feel free to email me. You continue to do your reading assignments. Make sure you get prepped for your quiz due by Sunday night. But remember, this week also, you have a live in-person proctored exam. That will be a written exam in person. Feel free to reach out if you need anything. This will conclude cardiac emergencies for this block for EMT.